So what we need to do is sort of try and reverse the hospital environment to become an environment where the stroke survivor is expected to do a lot. Now that's hard in hospital because most of us, when we go into hospital, we expect to be looked after, true? We expect to be cared for. And so sometimes it is difficult to try and reverse that thinking in a stroke unit or somewhere where people who've had strokes are being cared for. It's difficult for us to set up what we would call an enriched environment, an environment that's expecting you to do things for yourself. What therapists do is they deconstruct the task first into its component parts. So if, for instance, you're wanting to just butter your toast in the morning. A therapist will deconstruct that task into its component parts and they'll assess the ability that you have on each of those bits of that activity. Then they'll diagnose what's adversely affected. So is it sensory that's a problem? Is it motor that's a problem? Is it your vision that's a problem? What is it is it particular movements that you've lost rather? They'll diagnose what's going wrong and why. Then they'll prescribe a treatment plan, and what that treatment plan will be targeting is the mismatch between what the survivor can do and what the survivor needs or would like to be able to do. There's a mismatch, isn't there, post-stroke? So the therapist is trying to press the can-do further towards the needs and wants to be able to do. Then what the therapist does is they'll get you, the stroke survivor, to practice the task's component parts. They'll work towards regrouping some, most, and if feasible, all of the component parts, and then they'll aim towards reconstructing the whole task. True? Because if the evidence indicates that if the therapist isn't working towards the whole task, and this can apply to the carer as well, then the person's likely to lose motivation. And that's fair enough, isn't it? You get stuck doing component parts, it can be pretty boring. So the evidence is indicating that we need to keep the whole task front and centre. And the final R is for the rewards. We need to make sure there's extrinsic rewards. And as a therapist, for us that would be saying, Mrs. Smith, you've just done a great job today. You've worked so hard. It's all that sense of encouragement. That's extrinsic, outside of the person. And intrinsic is built in. It's looking at things like somatosensory and visual feedback. But what's interesting about the evidence is that the extrinsic feedback, and that's carer or therapist, needs to be fading. Otherwise, the person becomes dependent on it, true? So it's important that that feedback fades. Because constraint is something that there's bucket loads of evidence to say it works. And what constraint is, you actually put a mitt, and I wouldn't say a sling. Some people use a sling, but I wouldn't use a sling post-stroke. You apply a mitt or a sock, thumbless, onto the less affected arm. And the reason we do this is because we've learned that you can actually do lots of things one-handed, true? Post-stroke. You can do that post-baby too. You learn to do things marvellously, post-broken arm, with one hand quite well. And what happens is, as you're trying to recover from this stroke as quickly as you can, you actually learn to get very good at doing things one-handed. But long-term, there are things, bilateral things, that you want to be able to do. And so the other arm needs to come back into play. And constraint works really well on this. What you do is you put a sock, not in it, but on it. You put a sock on the less affected hand, and that takes it a little bit out of the picture and enough to press in the affected hand. So we talk about learned non-use and forced use, and it works well on the 20-10 club. The 20-10 club are the people who have 20 degrees there and 10 degrees there.